Yes, ma'am.
Padma, we can
Okay,
hear.
okay,
We can,
thanks.
yeah,
Thanks.
we can see the slide also very well. Yeah.
Okay, no, is Michael here? Michael, have you joined?
Yes, I've been listening in.
Hi, Padma here, and Rohit is there with a big hypertension looming up. His systolic is already touched 200 because of all the technical things that we are facing. Virtual or not, this is really one of the risk factors to get a stroke. Believe me. So anyhow, so welcome back after that technical fault and having connected back, and it is a great pleasure to welcome all you again, and welcome especially Michael. I don't know what time it is now. 7:30 in the morning. Okay. Good morning there. So this is one of the topics which is most relevant to the pandemic, and this was introduced as one of its kind of a thing to up the benchmark of today's summer school. So this is all related to the COVID times that we are living, the times which are completely unprecedented, and learning new things every day, continuing to be on the learning curve, and a lot of neurological issues which have been associated with COVID. It's gone much beyond the ILI and the SARI issues that they were first introduced as. So in this, we have 3 talks, and it's my great pleasure to invite my co-chair, Professor Michael Hill, and Shweta, where's the CV? So, well, forget about my CV. That's not important. Yeah, we'll get Michael's. So he is there at the University of Calgary and President of Canadian Neurological Science Federation, Professor, Department of Clinical Neuroscience. And I think is one of the finest, strokologists we have, and truly an icon. Welcome, and it's a great pleasure to have you here, Michael. And I give it to you to introduce the first speaker, our very own Rohit Bhatia. Please come, and hopefully your blood pressure is much better now.
Okay. Yeah, sorry, Rohit. I didn't follow what was just said. Maybe my connection was poor. But yes, please go ahead. I think, sure, off you go.
All right. Thank you, Mike, and thank you, Dr. Padma. So I think my talk was about the causation hypothesis in COVID-19 and stroke, something which we all have been very interested about. So I'll start with the main concept about how common is stroke in COVID-19. So when we looked at a meta-analysis we did last year at the beginning of the pandemic with some of my students, Dr. Padma and a colleague from PGI Chandigarh, we had an estimated projected about 4 to 5% of stroke. In that time, published cases of about 115 patients of COVID-19 and stroke, we found that ischemic stroke was the most dominant. It was in about 87% of patients. And also intracerebral hemorrhage, which was lower, which was about 5.2% patients, and then CVT and others. So, well, that time the case series were taken as a broader series. Some of them were case reports. So it was a conglomeration of all kind of early reports of stroke. And I think after that, the data has grown and we have known much and more. But one thing is very clear, that ischemic stroke still dominates than intracerebral hemorrhage. So a recent paper which looked into their own database of 27,676 patients of stroke and COVID-19, they actually analyzed a hospital-based database where they looked at patients who were admitted with any form of COVID-related, scenario where they suspected people to have COVID-19. Out of them, there were people who came out to be COVID-19 positive, and there were people who did not turn out to be COVID-19 positive, and they looked at how many of them actually developed acute stroke. So among these patients, among the COVID positive and 7,606 with no new stroke, 103 with new strokes, and COVID negative also had acute ischemic stroke of 199. So they found that if you look at the demographics or comorbidities or outcomes, there was clearly a worse outcome among patients who had ischemic stroke versus non-stroke. And between COVID positive and negative, they found some increase in the non-routine discharges, so they stayed more longer in the hospital. So they came out to the fact that what we believe generally that COVID-19 would have extreme degree of strokes in patients was not really proven very far in this patient, but this is again the electronically collected database, and this is of course not a large sample. It's a good sample, but this suggests that yes, it's a small incidence of stroke in patients with COVID-19. With the same group, they analyzed the data of the ICH patients, and how many patients actually get ICH among a cohort of 282,718 hospitalized patients with suspected COVID-19 and then proven COVID-19. So that's what the data was. Among the 85,645 COVID-19 patients, 0.2% developed ICH. And among the non-COVID, 197,000, it was about 0.3%. So the data was actually small. So the actual incidence of ICH was extremely low. But if you look at the comparison of data, what I want to show you is that among patients who actually had COVID-19 but without intraseptal hemorrhage and patients who had COVID-19 with intraseptal hemorrhage, you see the two red lines drawn, there's a clear increased prevalence of risk factors among patients with ICH and COVID-19. So which obviously means that there is an interplay of some risk factors which kind of get worse or probably poorly controlled or whatsoever you may say it. But they really also lead to probably the occurrence of this kind of usual strokes in these people. And if you compare the risk factors in general, there's a clearly increased risk factors in the population with COVID-19 as well. So higher risk factors pre-morbid, the higher you have a chance of getting a stroke if you are COVID-19 positive. So that makes it a bit more clearer with this data. Another systematic review, which is a more recent review, which looks into different pathophysiological estimates, clearly also suggested that the pool incidence of hemorrhagic stroke was 0.46% and of ischemic stroke was 1.1%. So this is repetitively coming that we probably have an incidence of close to 1 to 2%. But if you look at the population-based estimates and look at the number of patients who have had moderate to severe COVID-19, probably a large number would have developed or would have a tendency to develop a stroke. You know, if you look at the population-based numbers across the globe. So what could be the possible mechanisms? And this is an image from one of our previous reviews, which we wrote in the beginning of the COVID-19. And if you look at this, this was a pictorial image drawn by me, and of course, with images translocated from here and there. So there is something to do with the different forms of underlying, mechanisms, which includes the COVID-19 receptor of ACE2. It includes the cytokine response. It includes the plaque destabilization hypothesis, presence of risk factors, and all interplay, which I'll be touching down in the next few slides. So let's look at the COVID-19 and the ACE2 pathway. So what does ACE2 pathway do? In a normal person, if you look at the ACE, it cleaves the angiotensin 1 to angiotensin 2. And then the angiotensin 2 is cleaved by the ACE2 into angiotensin 1 and 7. Okay. Now this acts through a specific receptor called the Mast receptor, and the angiotensin 2 acts through AT1R and AT2R receptors. What does the angiotensin 1-2 do? It's called vasoconstriction, bad inflammation, fibrosis. This is kind of not short-term, but it's like long-term and short-term both. But if you cleave it to angiotensin 1 to 7, it actually causes vasodilatation. It's protective. It's also protective for some things. But what is happening is that the SARS-2 COVID-19 virus actually probably deregulates the ACE2. It binds to ACE2 receptor. So it deregulates. With this, there is a potential chance that you will have an increased angiotensin 2 pathway coming up, which is going to cause a lot of vasoconstriction and inflammation. In fact, if you all remember as students, there were a lot of data which came up that whether ACE inhibitors should be given to patients of COVID-19. And well, that was just probably bypassed and said probably that's not true, because in fact that could be protective rather than harmful, because you're going to do that. So this is one of the RAS activation pathways. And this is more pictorially to show that there is, of course, more vasoconstriction in presence of angiotensin 2. And we lose the protective effect of angiotensin 1 to 7, which will actually happen if you have enough ACE2 in your body. Okay, so one of the trials which had started but never went through is giving ACE2 protein. separately to patients of COVID-19. So let's look at the second concept of infections and stroke. We all see that we like to ask patients, did you have any recent viral fever? Did you have any recent infection? We are more predilected to ask this when we talk about neuropathies or GBS, but we're not really predilected to ask about it when patients come with stroke. So we have, of course, a direct mechanism in TB. We have a direct mechanism in syphilis or a fungus or a varicella zoster, which we all are very aware of. But we have many other interacting mechanisms, cytokine pathway, prothrombotic state. We know infections downregulate protein CNS. And we also have interaction of various risk factors which may get worse. So how does the data look like? So this was an old paper which came way back and which actually looked for infection as a trigger for different admissions and stroke subtypes. So they took a large data. They asked people about any infection in day 7, day 14, day 90, day 120. So they looked at the time gap between the last infection and probably the incident trigger, which was, of course, controlled for many factors. And of course, they found that there is, of course, an increased risk with the recent UTI and a lower estimates with ICH. But they did find the exposures causing infections. And later, people started looking at different viruses, influenza, and all that. And we, of course, found that in a California database that if you have any influenza-like exposure in the past, it increased your risk of having a stroke in about 2.88 odds. Now, why I put this specifically for influenza is because I'm talking about SARS-CoV-2 virus. So this is a respiratory pathogen predominantly, and so probably may be having a neuroinvasive potential. And if you look at a pictorial picture of this, that the SARS-CoV-2 could attach to the surface epithelial cells drawn on the right up. It could get into the blood vessels and go down and cause endothelium dysfunction. And it could also be uptake by the peripheral nerve endings. And then, of course, reach the CNS. The final common pathway, of course, is the development of endotheliopathy, thrombosis, cytokine overactivity, myocarditis, and so on and so forth. So these are potential mechanisms which could draw out. Now, what is the evidence of endothelial dysfunction or vasculitis? This was a lot talked about. And this was the first paper which came as a small report in Lancet. So in this paper, they found that 3 patients had died. One of them a renal transplant patient. So they biopsied the samples from the intestine, the kidney, and some tissues. And they actually found that there was a lot of inflammation within the vessels. Now we could say whether this could happen because of sepsis, this could happen because of one thing or the other. But this was the earlier report to suggest that there's an endotheliopathy in patients with SARS-CoV-2 biopsied samples. Then came another report which talked about the biopsy specimens and the imaging of a patient of stroke who died, and they found microbleeds. They found infarcts, and specifically caspase-2, which is a part of the apoptotic pathway. They found inflammation and caspase-3 activation within the vessel wall lumen, but it was not there in the parenchyma. So there was a strong suggestion in this report as well, with all the due limitations, that there is probably some evidence of inflammation in the vessel wall. Then few reports started to emerge where people did vessel wall imaging, and they started to look at the pattern of strokes, the availability of the vessel wall showing thickening and enhancement. And they started talking that probably this is an indirect way to suggest that these people may have vasculopathy, which is of inflammatory nature, which is probably triggered by a lot of factors. But unfortunately, most of these patients are sicker. These patients are not always available for an MRI. There are many constraints to do it in COVID. So the large data of these kind of evidences are poor in literature to suggest that. Let's come to the third part of the story, which is building the maze to the inflammation. So much about cytokine storm that every company wanted to make a monoclonal antibody to fight it. So there is a lot going on as a prothrombotic state in inflammation. And there are many of these beautiful small systems in our body, including platelets, lymphocytes, macrophages, and all that, and wall-relevant factor and so on, which actually come up and they start dysregulating the system. And when they dysregulate the system, what the neutrophils do is they have something called the neutrophil extracellular traps. These are called the NETs. If you like to read pathophysiology, you'll find a lot about NETs. What the NETs do is that they start developing these kind of prangs around them, which have a lot of histone and proteolytic proteins. And that's the way the neutrophils actually act. When we looked at our own database and the paper is in press and we want to look at the fraction, we found that most of the COVID patients had very high leukocyte counts compared to patients without COVID-19 and stroke. So there is a possibility that this whole triggers a milieu of mesh, dirt, with activation of platelets and produces thrombogenicity. So there is a lot to do with this. And another theory came about was a mast cell activation, and mast cells are bad. They secrete a lot of cytokines, histamine. They activate all these pathways and eventually lead to a lot of destruction in the neurons. They can disrupt the blood-brain barrier. They can disturb the endothelium, and they can cause a lot of microbleeding, stroke, and so forth. So these are different kind of conceptualized pathways in COVID-19. What would they finally do? In practice, we all like to look for these crazy biomarkers. Quickly, let's do ferritin, let's do platelets, D-dimers, and so on. And you will find that there are multiple studies which have looked at all these components in COVID-19. They never will help. They will never develop stroke in singularly. There will be a pathway which will get affected. And these are all driving a sense to us that there is an inflammation which is significant in these people. And that's what it eventually would do. You will have a SARS-CoV-2 which will damage the endothelial cell. The D-dimers are going to go up. The endothelial cell starts misbehaving. It also, somehow the granulation, the granulocytes kind of deregulate themselves. We activate the platelets from inactivated platelets. Then the wall-Wilburn factor comes in. And what we are looking at is within the vessel wall, tiny small vessels of the brain, where there's a milieu which is bad. And there is a potential that these people could get a stroke. So all of this would eventually lead to formation of these pathways. And if you look at, when we looked at our own systematic review, and we found that there was elevated D-dimers and C-reactive proteins significantly among survivors and non-survivors. So people who died, among the people reported, had very high levels of C-reactive protein and D-dimers, and of course, lactate dehydrogenase, suggesting that probably among the people who are sicker, these elements seriously go up in their system. In one of our in-press paper, which talked about, which I showed you about the COVID positive and negative data, also we found that the ferritins were high, the D-dimers were high, and the TLC was high in these people, suggesting that the inflammation definitely plays a part. In a small recent D-dimer related systematic review, because it's been of interest to most of us, they found that the D-dimers tend to be much higher among patients who were selected in these studies. Of course, this is an indirect suggestion that these are all COVID-19 patients. They're not COVID-19 and stroke patients specifically, but it suggests that there is something going on. So what will it suggest you? What are you going to do with a patient of COVID-19 in the hospital? Knowing that this goes up, that goes down, is not going to help the patient. The patient is going to ask you, what are you going to do about me? And how are you going to treat me for this? So there are some recommendations which came up over a period of time with different committees, putting all this into perspective. And on the right side are probably the drugs which have a potential for research. It's like sometimes we come to know that someone known to us called up a physician, I have COVID, is doing well. He says, quickly start Debigatin. So, all of this needs to be taken in perspective. So the current recommendations predominantly to start low molecular heparin are among patients who are hospitalized and relatively more among patients requiring ICU care. And most of you residents and most of the colleagues who worked in COVID-19 would realize that use of heparin had gone up tremendously during this period. And that's clearly because there is a suggestion that these people are sicker and they will have venous thromboembolism, they will have pulmonary embolism, or they may even have a stroke. But at the downside of it is we don't really know that when there is an increased endothelial dysfunction, it will breach and they may bleed also. So there is going to be a concern, and either way concern to manage these patients. So let's look at the final frontier of the story, risk factors. Don't forget that an 80-year-old man who's hypertensive, diabetic, is down with the COVID, has anyway got an increased risk of stroke because of the milieu being very distorted. So when we looked at the risk factors among the systematic review, we found that risk factors were very prominent in these people: hypertension, diabetes, old stroke, atrial fibrillation, dyslipidemia. They're not uncommon from the usual population. So it is very clear that many of these patients will also have underlying risk factors. Now, there may be a bias that many of these people will be in that age range, maybe 50 and above, or 40 and above, or 60 and above, who would have who would have had more severe COVID-19 and had a stroke. That is, of course, judgmental. But what would these do? So you have, like, for example, different form of risk factors called older age, LVH, diabetes, CKD. This will have different mechanisms playing their own part in a patient of COVID-19. These people could develop more endotheliopathy. They will have more dysregulation of immune response. They could have more chronic inflammatory response in the body. And each and every risk factor is going to contribute to development of stroke in a different manner, of course, with a common pathway of more thrombogenicity. But all these risk factors are important. In fact, in our own paper, we found that renal dysfunction among patients was much higher who had COVID-19 and stroke compared to ones who did not. And renal dysfunction has been shown to be a risk factor for a poor outcome in COVID-19 as well. So all of this actually plays a part. And this also helps us to understand how do we actually will, what we call subtype the ischemic stroke. Because a lot came into the literature about large artery stroke in COVID-19. But I don't think that's absolutely true, because different mechanisms are happening in different people. Cardioembolism may be also high because they may develop more atrial fibrillation due to myocarditis. We don't know. But all of these factors will eventually play a part and may help us in more suggestion and more suggestibility of the type of stroke as well. So in my last two slides, I would just like to say that you have these different factors: the ACE2 inactivation, virus-related cardiac injury, coagulopathy, CNS endothelitis, and critical illness. They will all have their steps to play, either in developing of ischemic stroke, or in the development of intracerebral hemorrhage, or in the development of CVT. The final common pathway looks like something like this. And this image comes from a very recent systematic review in International Journal of Stroke. So you have a gentleman who unfortunately develops COVID-19. Now this leads to hypercoagulation and promotion of venous thromboembolism. The increased inflammatory response triggers damage to the cardiac structures. The blood pressure goes vary because of ACE2 inhibition. There is more of a myocardial injury. There is increased blood-brain permeability. And finally, the pathway of development of either a hemorrhagic or an ischemic stroke. So in my conclusive remarks, what I would like to say is that we've understood that stroke does happen in COVID-19. We also have understood that they are at a higher risk of stroke, especially if they have more risk factors and if they're sicker patients of COVID-19. The stroke is not as large as we used to think that it happens, but it is still, in a population estimate, not insignificant if you look at the large number of patients who have COVID-19. And the multifactorial mechanisms will be interplaying their part. And of course, as suggested from the data, people with larger evidences of inflammatory response and with higher background risk factors are at a higher risk of developing a stroke. And I thank you all for a patient hearing. Thank you very much.
Okay, thanks, Rohit. I think what we'll do, if it's okay, is we'll go through all three talks. I see a couple people have their hands up, but maybe better if we just go through the talks and then have the discussion at the end, if that's all right.
Sure. Yeah, Mike. Sure. Yes.
Is that okay? All right.